So my lab at the Helmholtz Diabetes Center in Munich is focused since many years on understanding how GIP and GLP-1 GIP co-agonists act in the brain to regulate metabolism. And a few years ago, we discovered that long-acting GIP needs the brain GIP receptor in order to decrease body weight and food intake. We could also then show that the dual agonist, the GLP-1 GIP dual agonist, loses its ability to yield superior weight loss in animals that lack the GIP receptor in the central nervous system, indicating that the brain GIP system regulates energy metabolism by decreasing food intake and body weight. We then moved on to identify the neurons by which GIP regulates energy metabolism and found that it's the GIP receptor neurons that are GABAergic. And when we eliminate the GIP receptor neurons that are GABAergic in the brain, we find that the dual agonist loses its ability to yield superior weight loss over GLP-1. Very recently, we then asked the question, does maybe also the GIP receptor antagonist decrease body weight over the same GABAergic neurons? And we found out that GIP receptor antagonism decreases body weight via a totally different mechanism. In other words, the GIP receptor antagonist decreases body weight by making the GLP-1 receptor neurons more efficacious. And this is very different to the GIP receptor agonists, which work in a GLP-1 receptor independent manner over the GABAergic GIP receptor neurons. So the latest clinical data indicate that GIP significantly contributes to the body weight lowering effect of the dual agonists by giving additional benefits when it comes to body weight loss, but also by acting specifically in the hindbrain to attenuate the emetic effects of GLP-1 receptor agonism. In other words, GIP helps GLP-1 to be better tolerable. On another note, we have just seen the publication of the SURMOUNT-5 data, where tirzepatide was used head-to-head in a comparison to semaglutide. And also here, the dual agonist was superior relative to semaglutide to yield greater weight loss. So in a nutshell, GIP helps the GLP-1 in order to yield greater weight loss and to be more tolerable. So how clinically significant the synergy is in human studies is a little bit difficult to find out, because the human GIP system is a little bit different to the rodent GIP system, and tirzepatide, for example, does not sufficiently bind to the mouse GIP receptor to decrease body weight. But what we know also from the human studies, there was a clinical study by Novo Nordisk where they added a long-acting GIP receptor agonist on top of semaglutide, and they found that this combination then yielded to a greater weight loss, indicating that there is a true synergy in the weight loss between GIP receptor agonism and GLP-1 receptor agonism. So I'm very sure that we will see in the future a variety of more molecules. We ourselves are already working with one molecule that activates 5 receptors at the same time. So we will go from dual agonism to triple agonism. We have retatrutide already in phase 3. And beyond this, I'm pretty sure we will also see up to quintuple co-agonism in the near future. And additional endpoints that you can address with future drugs are, for example, that you even increase lean mass in elderly patients. You can also eliminate or decrease the activity at the GLP-1 receptor and have more complementary pathways that you're activating. And this is then supposed to help basically the patients to have even less side effects, because the side effects originally come from GLP-1 receptor agonism. So if you are developing drugs that activate simultaneously other metabolic pathways other than GLP-1, then you can decrease the exposure at the GLP-1 receptor to a point where probably you have very, very little side effects coming from the GLP-1 receptor agonism.